Good morning, friends. Today, the topic of discussion is nose. The revision of nose we will be doing today, and various chapters, topics that are important from the exam point of view and which are also important in the topic of nose will be covered today. So basically today we are going fast forward through whatever we have learned and various important topics of nose. So today the topic of discussion will be the nose revision. First, as we know, the discussion of any topic will start from its anatomy. So the anatomy of nose, starting with it, the external nose, as we know, the root is above and the base is directed below. The nose is made up of osteocartilaginous framework. As we here can see, above there are nasal bones bilaterally and the cartilaginous portion below. The osteocartilaginous framework is made up of nasal bones as the ostium part, and the cartilaginous part is made up of following cartilages. First, it is the upper lateral cartilage. The upper lateral cartilage makes the majority of the cartilaginous part externally, and the lower lateral cartilage, also known as the alar cartilage, are also part of nose. It is made up of fibro-fatty tissues. As we can see here, the fibro-fatty tissues are placed between the cartilaginous portion. The sesamoid cartilage can also be seen here. It is a small cartilage between the upper and the lower lateral cartilages. The upper and the lower lateral cartilage meet at the center along with the septal cartilage to form the dorsum and the tip of the nose respectively. The septal cartilage, as we can see here, the lower lateral cartilage, it is a U-shaped in structure. It is also known as alar cartilage. The lateral part is the lateral crus and the medial part is known as the medial crus. The septal cartilage caudal part and the medial crus will form the caudal part of the septum. Also the fibro-fatty tissue forms the remaining part of the intercartilaginous junction. The septum, as we know, is made up of bone and cartilage. The bony part of the septum is made up of perpendicular plate of ethmoid and the vomer. The cartilaginous part is made up of the much bigger quadrilateral cartilage, also known as septal cartilage. Various other parts of the septum is also seen here, that is the membranous septum and the columnar septum. So the membranous septum and the columnar septum are forming the tip of the nose. As we can also see, the crest of the maxilla and the crest of the palatine bone take part in the formation of the septal part of the bone. Coming towards the lateral wall of the nasal cavity, the lateral wall of the nasal cavity is thrown into folds, that is the shelf-like projection or scroll-like projection from the lateral wall known as the inferior, middle and the superior turbinate. The presence of fourth turbinate, that is the supreme turbinate, is much rare or can also be seen in very less population. Here we can see on the lateral wall there is an area in the anterior-inferior part known as the nasal vestibule. Nasal vestibule is nothing but the skin lined lateral anterior-inferior part of the nasal cavity. It also has hair follicles and sebaceous glands in it. The nasal vestibule has the sebaceous glands in it, hair follicles, and any infection of Staph aureus at this part, the anterior-inferior part of the nasal cavity, lateral wall, may lead to vestibulitis or furuncle or boil can also be seen here. So now, as we know, the lateral wall is made up of turbinates and the portion below the turbinate is known as myitis. After getting rid of those turbinates, we come across these structures at the lateral wall of the nose. The inferior myitis, as we can see here, the only structure that opens in the inferior myitis is the nasolacrimal duct. The opening itself is guarded by the mucosal wall known as the Hassner's valve. So now, after removing the middle turbinate, what we are visualizing here is the hiatus semilunaris, the opening, the two-dimensional opening here between the uncinate and the bulla ethmoidalis, the space between the uncinate and the anterior portion of the bulla ethmoidalis. The two-dimensional structure is the hiatus semilunaris. The space through which the hiatus semilunaris gets open into the three-dimensional space into which the hiatus semilunaris opens is known as infundibulum. So these are the structures on the lateral wall of the middle myitis. Here there are also opening of various sinuses, and the openings of maxillary sinus, frontal sinus and the anterior ethmoidal sinus can be seen here in the middle myitis. Above at this level, you can see when the superior turbinate is removed, we can get access to this, the sphenoethmoidal recess. Here the sphenoid sinus will drain here in the sphenoethmoidal recess. Also the posterior ethmoidal recess open at the superior myitis and the sphenoethmoidal recess. So now coming towards the most important part in the lateral wall of the nose, it is the osteomeatal complex. Here we are focusing on the left nasal cavity. Here you can see the orbit, the maxillary sinus opening and the sinus itself, the inferior turbinate and the part of middle turbinate which is attached to the cribriform plate. So here at the level of the infundibulum and the hiatus semilunaris, that is the space between the uncinate process and the anterior part of the bulla ethmoidalis, here this part is known as the osteomeatal complex because it is also made up of ostium, that is the uncinate process. Also meatal complex, that is the myitis of various sinuses drain here, leading to very important structure, osteomeatal complex. Blockage of this osteomeatal complex in any condition may lead to blockage of the drainage of the maxillary sinus, leading to sinusitis. Coming down towards the nerve supply of the nose can be divided into the lateral wall and the septal wall. Here the lateral wall, the nerves that we can see are the anterior ethmoidal nerve and the posterior ethmoidal nerve. The pterygopalatine ganglion can be seen here, and the greater palatine nerve also takes part in the innervation of the floor of the nasal cavity. Thus the anterior ethmoidal nerve, the posterior ethmoidal nerve, also the branches of the infraorbital nerve along with the pterygopalatine ganglion may innervate the nasal cavity. Coming down towards the septal innervation, here we can see at the roof of the nasal cavity that there are the olfactory bulb giving down the olfactory nerves at the roof of the nasal cavity. The smell sensation, that is the olfaction, is due to this innervation of the olfactory nerves at the roof of the nasal cavity. Also, they are supplied by the nasopalatine nerves here at the posterior inferior part. The blood supply of the nose, as we have earlier seen, that there are two basic arteries that supply the nose. First is the internal carotid artery and second one is the external carotid artery. The internal carotid artery gives branch of the ophthalmic artery. The ophthalmic artery itself divides into anterior ethmoidal artery and the posterior ethmoidal artery. So these two branches will supply the upper part of the nose, whereas the lower part, that is the adjunction of the middle turbinate and below, the part of the nasal cavity is supplied by the external carotid artery. The external carotid artery gives two main branches, that is the facial artery and the maxillary artery. The facial artery gives the superior labial artery branch of the facial artery. Also, the maxillary artery will divide into sphenopalatine artery and the greater palatine artery. The greater palatine artery supplies that the floor of the nose, whereas the sphenopalatine artery gives branches towards the posterior inferior part of the nose. So this is blood supply of nose, that is main two basic arteries that supply nose will be the external carotid artery and the internal carotid. Internal carotid supplies through ophthalmic artery two branches, anterior and posterior ethmoidal artery, whereas the external carotid artery takes part in the blood supply of lower half, that is basically below that of the middle turbinate, and that part will be supplied by the greater palatine artery and the sphenopalatine artery itself. So now coming towards the physiology of nose, we have completed the anatomy of the nose, that is we have seen the osteocartilaginous framework, also the blood supply, nerve supply, and now we will start the physiology of nose. Whatever the functions that the nose conducts, they are the respiration, flow of air. So now whenever we talk about respiration, the flow of air will be laminar, that is the flow of air will be basically between the middle part, that is between the middle turbinate and the superior turbinate, and the various other airflow will be from some part will go towards the roof of the nose, whereas the some part will flow down the inferior turbinate. But the majority of the flow of air will be between the middle part of the nasal cavity, and that will be in the laminar flow of air. But this will be in inspiration. At expiration, the path will be the same, but at the junction of lumen nasi, the airflow will be obstructed, and that obstruction will lead to formation of Addis current. Addis current will lead to ventilation of the sinuses. The nasal cycle is nothing but alternate congestion and decongestion of the nasal mucosa due to the blood sinusoids present in the nasal cavity. The respiratory part is conducted by one nasal cavity at a time. That is the whole function of the nasal cavity. Both the nasal cavities is conducted by a single nasal cavity ranging from 2.5 to 4 hours. So at any given moment only one nasal cavity is functional, and the nasal cycle may range from 2.5 to 4 hours, and after that 4 hours completion of nasal cycle, the another nasal cavity will start functioning and the previous one will get some rest. So it is the alternate congestion and decongestion of the nasal cavity. Also the air conditioning of the inspired air is undertaken, that is the whatever air that we inspire is maintained at the temperature of 37 degrees Celsius, and the humidity of the air is also maintained at or above 70%. So also protection of lower respiratory tract, the mucous membrane and also the vibrissae that are present in the nose will track down or obstruct the various particles that may be harmful for the lower respiratory tract up to 5 micrometer diameter, and they thus protect the lower respiratory tract from any major allergens. The nasal reflexes, that is the gustatory and salivatory reflex on smelling food items and also sneezing is also a protective mechanism, comes under nasal reflexes. Olfaction, as we have earlier seen that the roof of the nose is supplied by the olfactory bulb and the nerves, which will further go down towards the prepiriform cortex and the amygdaloid nucleus, leading to sensation of smell. Any disruption in this sensation of smell will lead to various olfactory disorders, that is the anosmia or hyposmia, phantosmia, etc. Coming down to the diseases of external nose and vestibule, the nasal deformities like saddle nose, hump nose and crooked nose will be seen due to any trauma or excessive resection during surgery will lead to saddle nose, that is the bridge of the nose will be depressed, hump nose, that is the congenital excessive bridge or the cartilage present. Also crooked nose is due to a trauma that has occurred. Benign tumor, that is rhinophyma, it is nothing but an hypertrophy of the sebaceous glands present over the external part of the nose. The treatment for rhinophyma is in toto resection of the rhinophyma. Malignant tumors, main is the basal cell carcinoma, that is the rodent ulcer. Rodent ulcer is common in 40 to 60 years of male and female. Female predisposition is much larger. Also, the basal cell carcinoma at initial stages can be removed by resection, leaving a margin of 5 mm over it. And the nasal vestibule, as we have already seen, that it is the skin lined anterior inferior part of the septum, and it also contains hair follicles and sebaceous glands. So any staph aureus infection at this level to the hair follicles will lead to furuncle and vestibulitis. The treatment of this will be incision and drainage if there is any pus formation, and also there will be antibiotic, IV antibiotic can be given further. Nasal septum, as we have seen, there are two types, that is the fractures of nasal septum can be divided into Jarjave type and the Chevalier type. The Jarjave type is due to the blow of trauma anteriorly to the nasal septum, leading to the fracture which goes from the nasal spine towards the perpendicular plate of ethmoid. It is almost running towards the perpendicular plate of ethmoid through the septal cartilage. Whereas if the trauma is given from the lowermost part of the nasal septum, then the fracture line runs from nasal spine towards that of the osteocartilaginous junction. It is a horizontal fracture, as we can see in the picture. It is the Chevalier type. The previous one was of Jarjave type. Nasal septum also comes with the pathology of DNS, that is there are types of deviated nasal septum. It may be C-shaped. The anterior dislocation can also be seen. S-shaped nasal deviation, nasal septal deviation may lead to bilateral obstruction of the nasal cavity, and also the spur, that is the shelf-like projection from the osteocartilaginous framework, can be seen here. So treatment of this deviated nasal septum may be submucous resection and septoplasty. In submucous resection, we elevate both side flap of the septum and the deviated part is resected, whereas at the septoplasty, the whatever one-sided flap is elevated, only removal of the deviated part of the septum may be seen. Cottel's test can be seen here by pulling of the cheek here. If there is any obstruction at the level of nasal valve, then just retraction of cheek on that ipsilateral part. If it relieves the obstruction, then we are sure about the obstruction of nasal cavity due to at the level of nasal valve. Septal abscess and septal hematoma are various other pathologies. Here the septal abscess and the hematoma leads to bilateral obstruction of the nasal cavity. Any excessive resection or complications of nasal septal abscess may lead to septal perforation. Thus, the treatment for this septal perforation is placement of a button, elastic button can be placed here. Atrophic rhinitis, as we have studied earlier in our lectures, here the etiology, as I have earlier told you, it is of hernia, Hernia. H is for hereditary reasons. If H is for any hormonal imbalance, then various endocrinal imbalance can also be seen. Hereditary. R is due to any racial factors. Then nutritional factors, that is any deficiency of vitamin A, D and very micronutrients may lead to atrophy of the nasal mucosa. Immunology and autoimmune function of the body may lead to atrophy of the nasal mucosa. Here the normal columnar ciliated epithelium of the nose is replaced by the stratified squamous epithelium. That is the main what you can say basic of atrophic rhinitis. Treatment here is medical and surgical both. Medical treatment is nasal irrigation. Nasal irrigation, as I have already known, it is the mixture of solutions, that is the sodium biborate, sodium bicarbonate and sodium chloride. These mixtures at in 280 ml of water is given, and the nasal douching of the nasal cavities is done. 25% glucose in glycerin, it gives rest to the nasal mucosa, and also the secretion of the nasal glands is also increased. So local antibiotics, estradiol spray, placental extract, streptomycin 1 gram per 1 gram per day is given for this atrophic rhinitis case. Potassium iodide orally will improve or increase the nasal secretions, thus giving rest to the nasal mucosa, which is already very dried and necrosed. Surgically modified Young's operation is done. Here the flaps are elevated bilaterally and some space is left here in between, that is different from the Young's operation. Narrowing of nasal cavity by Teflon paste, fat and cartilage etc. is done, that is the cartilage graft Teflon paste is injected submucosally and narrowing of the nasal cavity is done. In granulomatous diseases of nose, we ask, that is the formation of sporangia, endospores, and again breaking down of the sporangia leading to spread of various endospores. Diagnosis is made by using that of biopsy. Treatment is whatever the rhinosporidium is seen, it is removed in toto. Wegener's granulomatosis is also important, granulomatous disease of nose, whereas it is necrotizing vasculitis, lungs and other features can also be seen like kidney involvement. Various amount of destruction of the nasal structures can also be seen here. In case of CSF rhinorrhea, difference between CSF and nasal secretion should be known. That is, the CSF here will give an halo sign or double target sign on collection over the filter paper, whereas the nasal secretion, as it contains mucus, it will lead to tightening of that filter paper. Also the CSF, in CSF the glucose content is much more, that is more than 30 milligram per dl, whereas in nasal secretion the glucose content is much less, that is 10 milligram per dl content of glucose can be seen here. Lab test, that is detection of beta-2 transferrin and beta trace proteins are done to detect CSF. Radiological studies, that is the CT scan, MRI scan, to detect any fracture, CSF leak or herniation of brain parenchyma can also be seen. Fluorescein study can also be done here. 5 to 10% of fluorescein is injected into 10 ml of CSF, and that is again injected into the through the lumbar puncture by using blue filters. That is the nasal cavity when inspected, that is here we can detect the CSF in roof of the nasal cavity. Treatment will be neurosurgical intracranial approach, extradural approach and transnasal endoscopic approach. In case of allergic rhinitis, it is the main signs that we can see is nasal congestion, rhinorrhea, sneezing and itching, impairment of smell more than an hour a day, IgE mediated type 1 hypersensitivity reaction. Here the vasodilatation and capillary permeability is increased, leading to rhinorrhea. According to current classification, it is intermittent and persistent. In intermittent, it is less than 3 to 4 days per week, less than 3 to 4 weeks. If it is more than that, it is persistent. Here the signs that we see will be allergic salute, that is a horizontal crease will be marked over the dorsum of the nose. Rhinorrhea will be seen and congested conjunctiva along with DNS can also be seen. Medical treatment will be intranasal steroids, leukotriene receptor antagonist, oral mast cell stabilizers and antihistaminics will do. In case of immunotherapy, the allergens are injected according to increasing dose till the plateau phase is reached. What it will do is reduce the specific serum IgE level, reduce basophil sensitivity and increase IgG blocking antibody level. Surgical treatment can be done by using septoplasty. Vasomotor rhinitis, only sign that is missing here than from allergic rhinitis is that of itching. No itching and all allergen tests are negative. Medical treatment is for avoiding triggering factors, intranasal steroids and antihistaminics. Surgical treatment, turbinectomy and Vidian neurectomy is done. And coming to the last topic here, the nasal polyp. The difference between AC polyp and the ethmoidal polyp is must. AC polyp is seen in children, it is an infective etiology, and the ethmoidal polyp can be seen in adults due to some allergen or allergic etiology can also be seen. AC polyp is unilateral compared to ethmoidal, which is bilateral, and grape-like structures can be seen. Multiple ethmoidal polyp can be seen. AC polyp has three parts, that is the antral, choanal and the nasal part, whereas the ethmoidal polyp will project out from the anterior nares. Symptoms and signs can also be seen, that is nasal obstruction, allergen, it is allergic to dust can also be seen here. Treatment, conservative treatment by medical treatment can also be given. FES is the major surgical approach. So here we can conclude to that of overall nose revision. The theoretical topics have been covered here. Thank you.